So I guess I'm going to be the only one that talks about not bones. So I talk about the stuff that's inside the bones. I'm kind of like the interior decorator of the building. So my stuff's going to be a little bit different. The other thing is I treat babies mostly. My area of expertise is newborn kids with congenital diseases, spina bifida, things like that. And my approach is always to sort of try to prevent things rather than treat them once they've gotten a little bit worse. So we've heard a lot today about, in fact, I've learned a lot today about the formation of the bone and what's going on in there. And for me, what I care about is that bone is holding the important neurological structures. And it can have an effect on those neurological structures because of restricted growth. So I'm a simple man from Minnesota. And the problem here is space. From a neurological standpoint, it's constricting things in there. The severity of the conditions that I see of kids with metabolic bone disease, because we don't treat enough as neurosurgeons kids with HPP to say we're experts on that. It's more kids with other conditions that are affecting these same structures, and then kids with metabolic bone disease and how those might vary the kids that we see with just a Chiari or craniosynostosis. And to be honest with you, a large series are lacking. So when I was sitting over there listening to these amazing speakers and hearing you guys with your passion, I thought, I better talk to my colleagues and get all of our data together, and so we can give you some more information. So I literally emailed them when I was. That doesn't mean they're going to email me back any more than they email you guys back. So. So here's the sort of group of metabolic disorders of bone disease and how they affect my world, which is the brain and the spine. And the two conditions that you're going to hear about today are really the ones that are sort of are the ones I treat, and that's craniosynostosis and Chiari malformation. And my goal is to tell you how I treat it, so that, and why I treat it and what we're treating, so that when you go in there with your family member or with yourself, you're going to be a little bit more savvy as to what's going on, and maybe educate the doctor as well. So today's goal, again, to discuss craniosynostosis, Chiari, from a diagnosis and treatment, and then just to give a little bit of nuance on how metabolic bone disease can affect those treatments. So the first thing is craniosynostosis. So what is it, what isn't? It's not just an abnormally shaped head. What craniosynostosis is abnormal sutures fusing. They're fusing at the wrong time. So you all were born, you're here, with a soft spot in the middle of your head. Most of you have children too, and you know that soft spot. You can feel that soft spot. Radiating out from that soft spot are the sutures. You see this on every Halloween skull, those little bone plates. And that's where the skull's kind of growing early on, and it has to be like that because when a baby's born, they have to fit through the birth canal, and the birth canal is too small. And so you don't want to get a skull fracture, so it fits through, the baby fits through the birth canal. The other reason is the skull rapidly grows that first year of life. You all saw your growth curves, and you can see that sort of ramp up. In that first year of life, there's a rapid growth, and those suture lines allow that rapid growth to happen. Now, what craniosynostosis is when those suture lines abnormally fuse, and they're supposed to get a signal to fuse and then zipper up like a zipper in an organized fashion. When they don't, when they close too early, then the skull and the brain want to continue to grow, and it'll push in a perpendicular fashion to where the suture's closed. So if the one in the middle closes early, your head will take on this elongated shape. If one closes in the coronal, it's like an old crown like you wear if you're a pageant winner, which I'm not. And so that's the coronal suture, and if that closes too early, then one face will be pushed forward or the other one. The one that you guys are probably most familiar with that you'll see in your kids would be sagittal synostosis, where this midline suture fuses too early. So children with hypophosphatasia or early can get craniosynostosis. It can be missed a lot of the time, in part because they might not have it when typical kids have craniosynostosis. It might occur a little bit later on, plus the bone might look different. So if you have very early onset, almost all the kids have some form of craniosynostosis. But to be honest with you, the largest series are only about 20 patients, so there's not really big series on it. The other reason it might be missed in your kids is that the typical way of diagnosis in the olden days was skull x-rays, which are terrible. And they're particularly bad in kids with metabolic bone disease because the sutures, you're not seeing the suture, you're seeing the lack of bone at the suture. And so if you're lacking bone in the other parts of the skull, then it won't have that pop effect on the... To be honest with you, skull x-rays are useless in general for craniosynostosis. We don't use them. They're very, very inaccurate. We do more by diagnosis by physical exam and then getting a CAT scan or something along those lines. The problem, again, in kids with craniosynostosis with metabolic bone disease is it might not have the same shape of kids with craniosynostosis because it can present later and because it can be multiple sutures and the skull growth can already be a little bit abnormal, so it's often missed. The first line of treatment probably is prevention, but in talking and hearing the talks today, I think that the institution of enzyme therapy might increase the number of patients I see with craniosynostosis. So you might want to have this in your back of your mind where you keep asking your doctor, are you sure it's not craniosynostosis? And so let's get to treatment because that's the cool stuff. The evaluation for kids with craniosynostosis is multidisciplinary. This should be done at a bigger center where the kid can be seen by a neurosurgeon, a craniofacial surgeon. The geneticist is always involved. Ophthalmologists are involved because the growth of the skull affects the skull base as well, where the eyes are. Neuropsychiatrists are usually involved because it can cause pressure on the brain and developmental problems. Otolaryngologists are often involved as well because the skull sits on the skull base, and so that can affect your nasal passages in your teeth and other structures. This example that you're seeing on the right is another form of genetic craniosynostosis called Apert syndrome, which involves fibroblast growth factors. But you can see the really odd shape the skull can take on when the sutures are closed. Other ones can pop open, things like that can happen. Now treatment, but first talk about the different forms. So these are the different sutures that can close. The one that goes down your head is the metopic, and before you guys all freak out because you have a ridge along your head, that's called a metopic ridge. That's just where your suture closed. So relax, you probably don't have metopic synostosis. These kids have a sort of a triangular shaped head. Sagittal is the most common one you see with kids with metabolic bone disease. That's the one in the midline. It's called scaphocephaly because it looks like the bottom of a ship, a keel of a ship. So they'll have a very long, narrow head and a very tall head. And then coronal synostosis occurs either unilaterally or bilaterally, and that's where the suture fuses and one part of the forehead will be pushed forward. The more common thing you'll see in your own kids at home, and my daughter had it, is plagiocephaly, where you have flattening of the skull. And that's because you're good parents and you put your baby on their back. And that's just molding of the helmet, of the head, and treated with helmets or other techniques. So that's not synostosis. So synostosis is sort of these sutures fusing, and that can lead to a worsening appearance, problems in vision, and can sometimes lead to developmental delay. We don't have great data on that. It appears that if we see kids who weren't treated and are now 8, 9 years old with just regular craniosynostosis, they do have a higher rate of having some developmental problems. But we don't know if treating it reverses that. We think it affects how the brain is sort of under there. Because if the skull's not growing properly, there can be restriction in the skull growth. That can lead to increased pressure, can lead to increased problems in the white matter, the sort of talking parts of the brain underneath it. And that pressure, we think, can lead to some problems in the skull and into the brain. But we're not sure, even in kids with just regular old craniosynostosis. So why do we treat kids with craniosynostosis? The biggest reason that we treat the kids is sort of that skull shape. But with kids with HPP, the underlying skull doesn't necessarily heal well, so people are hesitant to treat those kids. The bone's a little bit softer. And so the skull can have that hypomineralized effect to it. So that can affect how we treat it, and we'll talk about how we use screws and rods, and we heard from Dr. Fox as well. We have some tricks. We treat kids with problems with their bones commonly for craniosynostosis, so we have some tricks to get around even soft bone. So the goals of surgery for kids with HPP are the same as kids with craniosynostosis for other reasons. I treat a lot of kids with congenital conditions, and so at the first visit I see a family, I tell the family they're having a normal baby with a healthcare problem. HPP is a healthcare problem. It's not a person. And so we treat these kids with the same goals and with some little nuances, and it's a little bit easier to treat when you treat 4 or 5 kids a week with craniosynostosis to sort of adapt to when things are a little bit unique. The goal is to expand the volume of the skull to either a normal level or sometimes a supranormal level so the kids can kind of grow into it. We want to normalize the ICP, we want to reduce pressure on the brain, and particularly on the optic nerves as well, because they're in the skull as well. We want to allow sort of for normal skull growth in the patient afterwards, so that dictates sometimes the treatment we give. We want to make the kids look pretty just like their moms and dads and look pretty. Unless their moms and dads aren't pretty, then we want them to be pretty. We want to improve symmetry. I work with a craniofacial doctor named Dr. Taylor a lot, and I always say he's the pretty doctor and I'm the nice doctor. And he tells me that one of the hallmarks of beauty is symmetry. And to be able to see a face that looks symmetric is very important. And this is how they present themselves to the world, so we care about that. In kids with HPP and also with craniosynostosis, sometimes we want to treat the Chiari by making things bigger, and we'll talk about what that means in a second. So let's get into the cool stuff, right? The surgery, the stuff that my daughter thinks is cool too. So just giving you some surgical examples. These are just how we treat craniosynostosis, so you know the lingo and knows what it looks like when we do it. Denise told me to remove sort of the bloody images, so there's not as many sort of bloody images. And, hey, blame her. She said it's too shocking. I give talks to kids at their school sometimes too, and a couple schools like banned me, and so I've removed those now. There's still some cool pictures in here though. So the mainstay of treatment for decades has been something called vault remodeling, where we remove the bone, we reshape it, and we put it back on. We do that in the front and in between the eyes, or we do it in the back called the posterior vault. And those goals are to reshape the skull and then put it back on. You used to use wires and other things. Now we use absorbable plates most of the time. They're made out of plastic. They tend not to push through even soft bone because they're made out of this plastic that absorbs, and so they're not as rigid, but they're rigid enough to hold things into place. And so that's one of the ways we get past that. One of the problems with that is you're removing the bone, you can get blood loss. Almost all patients need a blood transfusion during that operation. It can affect how the bone heals, and you literally take it off and put it back on, so the bone's not alive after that. It has to be revascularized. And it's limited at how much space we can make. So over the years, we've developed less invasive options. Everyone likes minimally invasive. And one of the biggest ones is distraction osteogenesis. So as Dr. Fox showed in some of those cases where you put screws in and then you move the bone, that's called distraction osteogenesis. You space the bone out and then allow the bone to grow along those layers. So we make a cut in the bone, often posteriorly, and then we put little distracting devices on there and we push the bone. In fact, you do that. The parents turn a little screw on the side of the baby's head and pushes the bone to make it wider. And it works really well. It's less invasive. There's less blood loss. You're putting down real bone, living bone, and you can get a bigger expansion in the size of that. So this is a very effective treatment, but sounds dramatic, actually less dramatic than the bigger surgery. So here's an interesting case of a child. You see how one eye is below the other one? Came to see me because they thought they were having strokes or something, that one eye was droopy. Turns out it was the other eye that was up that was the problem. That skull wasn't growing. And so we cut the bone, and then we put a little device on there to push that forward in a trajectory and vector that we wanted. And so you can see the difference in the baby from the top corner to the bottom corner, and an expansion in that size of the skull, distracting that over time. There's another treatment that's very common. So you can do a craniotomy, you can do a cut, or you can do a strip craniotomy, remove the suture that didn't fuse properly, or fuse properly too quickly. You think, okay, why don't we just do that? That's what they did 70 years ago. They removed that little strip of bone and they said, well, that was the problem, so now things are fixed. It turns out the next signal from the body is to say, heal that bone, and it's healed within a month or so. in an abnormal fashion. So you have to apply some force to the skull. So that force is either a strip craniotomy with an endoscope or some other fancy tool, and then a helmet to push the skull. Or some places, like at CHOP, we put little spring devices in there. They look like little clothes hangers, and they push the bone apart. Again, if the baby has HPP, you want the baby on enzyme treatment so that bone's a little more solid. And then we also change the way that the force vector is pushed on the bone so it doesn't push through or plow through the bone. We use more than one, and we actually judge how much spring there is in those little devices. So it's important to know what the kid's condition is beforehand. And you can see in this baby who had sagittal synostosis, you can see how wide those springs are. Those springs were only 1 centimeter wide when we started, and they slowly expanded the skull and dramatically changed the shape of that kid's head. Then the springs come out. For these less invasive ones, not the other one, but for this one, we have to do it at an early age when the skull's still moldable. You remember your little baby had, sort of mushy skull early on. As you get older, above 6 months of age, the bone's too rigid for it to be moved by these devices, and we have to use that other device where we push it forward with the distractor. So again, this is the sad part of the talk, is that we don't know a lot about kids with HPP and craniosynostosis. A very small study out, I think, Cincinnati, just looked at a small group of patients, actually one of the larger ones in kids with enzymes, the only one published, and showed that it's safe to do with kids with enzyme. A couple of kids had it before, a couple of kids had it afterwards. And I think it doesn't dramatically change our treatment strategy, at least at CHOP, but I think it's going to increase the number of kids that we have because it changes the biology of that suture and the signals it's receiving to when to fuse and when not to fuse. And so we'll probably end up with more kids with craniosynostosis, not less, with some of the enzyme treatment. And we're sort of trying to collect that data. There are some nuances to kids with metabolic bone disease. Their bone tends to be a little more vascular in the inner layer. So there's 2 layers of bone, an outer cortex and inner cortex, and then a marrow layer in between. And they tend to be a little bit more oozy, a little more blood loss. So we have to anticipate that during the surgery. There can be veins that come through because of the high pressure. The blood has to get out of the brain through veins, and so there can be some more veins, and that's a subtlety that you need to know how to handle, or it'll lead to an injury to the underlying brain. And the dura, the coverings of the brain, can be thinned out from the pressure, so you have to be sort of careful about handling all those things. So just in summary of the craniosynostosis portion, the abnormal head shape, that's a common finding in the newborn period. Your pediatrician should be looking for that in the kids, but I think you should probably be looking for it. It sounds like everybody here from all the talks is that the doctors that you go to don't know a lot, and that you have to sort of remind them of all these things. The early recognition of that head shape abnormality is super important because then you now have all the treatment options open to you, including the minimally invasive ones. It's also easier to correct a deformity of the skull earlier because it's not as severe. It's easier to expand the skull. It's easier to get a normal result, of a cosmetic result. And it also is easier to change the skull base. So when things are abnormal because the sutures aren't fusing, it affects the face, it affects the skull base, it affects everything. And the skull base doesn't react to that expansion as well if you wait long. And so it's much better to get this treatment really early for kids. It increases their outcome, I think, for most of those kids. The complications, these never occur in my patients, but we have to talk about them anyways. You can have spinal fluid leaking, infection, contusion to the brain. All those things sound really severe and we don't like them, but they're really very uncommon. It's a very safe surgery to do, even though it's dramatic, where you're pulling the skin and moving bones around. It's an amazingly safe surgery, in part because kids are so good at getting better. One of the things that we already talked about was the blood loss in kids with metabolic bone disease. The other one is they can have gaps in the bone, or those areas where we cut the bone cannot heal properly. And so there's tricks we do in order to tell the body where to put bone. And that's something that has to be done carefully, otherwise you can end up with new fontanelles that you didn't want to have before. And then in all of my patients, I check their ICP almost always if the parents will let me, because I know what the ICP is then when we treat, and if they develop headaches or other things later in life, I'll have some idea that they had high pressure when they were younger, and we can sort of adapt to that. Most kids don't have dangerously high pressure when they're less than 3 years old, though. So it's something that we see more in kids that are older with that restrictive growth over time. So it takes a while to develop that higher pressure. The other condition we treat, and it's related, is a Chiari malformation. And this one is much more common in the public, so you'll hear more about this. Chiari malformations are very, very common. And what they are is it's the downward displacement of some of the brain because there's not enough space or there's pressure inside. And the part of the brain that is displaced downward is something called a tonsil. So just like you have a tonsil in the back of your throat, you have a tonsil in the back of your brain. It doesn't really do anything. I can get rid of it, and I can't find a signal problem with you if I get rid of it. It's this tiny little structure that hangs down, and there's a zoomed-in portion of it, a little tail that sticks down from the part of the brain called the cerebellum. It's the coordination part of your brain. This part pushes down, and that's right exactly where the fluid sort of flows in your head. So normal on the left, Chiari malformation on the right. So the normal CSF, the spinal fluid, is made in your brain and then flows down past this area called the fourth ventricle. And right next to it is where God decided to put this tonsil. And so if the tonsil is pushed down, either it's down there because you have a Chiari malformation, or it gets pushed down there because the pressure in your head is higher, it can limit how that fluid flows past that area. And that's where people get problems, because there's a pressure differential from the top to the bottom, and with each heartbeat, your brain pulsates. And so things that can accentuate that pressure difference can lead to headaches. But headaches are super common. 90% of the population has chronic headaches. And so just because you have a Chiari malformation and you have headaches doesn't mean the two things are always connected. But we look for things that sort of indicate that the Chiari might be the relating things. These are things that we call tussive headaches, things that bring on pressure. If you poop, remember I'm a peds doctor, if you poop, if you pee, we don't say the other things. Or if you bear down, if you're lifting a box, those things all naturally raise the pressure in everyone's head in this room. But if it does that and gives you chronic headaches, then that can be what we call a tussive headache. If your headaches are in the morning when you wake up, the pressure in your head, bless you, naturally goes up when you're overnight, and so you might have sort of Chiari-related headaches. The ones we treat are the ones that are causing those chronic problems or leading to a secondary problem of this sort of spinal fluid. Those secondary problems are the spinal fluid can't get by, so it decides to take another course. And that other course is into the brainstem and leads to something called a syrinx, which is the normal fluid that you have in your spine can expand up and cause a syrinx or a scoliosis. One problem about Chiari malformations that I find when I'm in my clinic is that if you Google Chiari malformation, I sure bet you will find something wrong with you that's on that list of Chiari malformations, because it's usually about 5 pages long, and they can be sort of really significant. So it takes time to sort of tease that out and the belief and trust in the person who's teasing it out that they're not just trying to get you out of the room. There can be brainstem problems. If the syrinx is in the brainstem causing dilatation, it'll affect the nerves that come off the brainstem. So you can have sleep apnea or breathing problems. You can have trouble with your eyes or nystagmus. Again, a lot of those problems can occur for other reasons, though. You can have cerebellar dysfunction. This is super rare, right? It's the cerebellum that's back there that's causing a problem. But if you're clumsy or you're falling a lot, if you don't have a syrinx, which is causing a communication problem between your brain and your spine, it's probably not the Chiari itself that's causing those problems. You can have spinal cord problems themselves. Progressive problems with scoliosis can occur if you have a syrinx that's enlarging. You can have syncope or lightheadedness or POTS type patterns. And you can also have something called basilar invagination, which is more common in kids with metabolic bone disease, where where the brain's not just sneaking down, but the skull is sneaking down over the spine and the spine's pushing up. So in HPP, the cause of the Chiari can be, I should say tricky, but also trickly, I guess, to pinpoint. And that's because it can be caused by two different things. It could be caused by pressure from above, from craniosynostosis per se, or it can be caused from the growth of the skull in the back of the head and just not having enough room for the brain to live in. So the Chiari can be caused. And so, and those would be different treatments, right? You'd either treat the craniosynostosis first, or you would treat the Chiari first, or vice versa, depending on what the major concern is. So surgery. Now we get to some of the sort of cool picture parts. Just like with craniosynostosis, there's a less invasive and a more invasive approach. The goal of the surgery is to decompress that area and allow the fluid to flow past. So it doesn't necessarily mean I need to treat the Chiari malformation. I need to treat the mechanism of the problem. That treatment might also be affected by whether or not there's a syrinx present. So the mainstay of treatment for the last 100 years has been something called an intradural Chiari decompression. You're making more space. So you remove the bone in the back of the head and at the top of the spine. You don't have to wear a helmet afterwards. It's way below all the structures down there. So kids can play every sport they want to play afterwards. You then open up the coverings to the spine and to the brain called the dura. Once we open that up, we're looking at the brain. And then in most places, we'll remove the tonsil itself or move it to the side so that the fluid can flow past. This is very effective. The advantage is you're directly fixing the plumbing problem. You're opening up that space, letting the fluid flow by. The disadvantage is you're directly operating on the brain, and so it has higher rates of complication. Can be upwards of 10, 15% of chemical meningitis or other problems. So for years, we've developed, last sort of 10 years or so, less invasive approaches, which can work. They work a little less as well as the intradural components because they're not directly opening up. We're just physically making more space. And so this is an edited version of what's called an extradural Chiari surgery. So as this starts, the bone work's already been done. The top of the head is to the left, the spine is to the bottom, and what I'm removing is I'm making more space for that fluid to go past. So there's a little band of tissue down where the head meets the skull that we remove, and then underneath that, I'm looking at the dura. And the dura is like fila dough. It's made up of multiple layers. So we can open up some of those layers and leave the layers intact. And the goal of that surgery is to make it so thin that it can pull, the brain can kind of have more room and balloon out. And so at the end of this, you'll see an area sort of pulsating underneath that, and that's the tonsil moving back and forth. This surgery works, but it doesn't work quite as well. So the success rate with intradural surgery is about 90% to get rid of your headaches or reduce your syrinx. With the less invasive, it's about 80%. But the complication rate's also 1% versus 10%. So that's why people may decide to do one surgery and then see if it works and then go on to the more invasive surgery. They might use a combination of both of those surgeries. And the big advantage is we're not opening up the brain and the spine, so there's a lower risk for infection or chemical meningitis. So Chiari surgery, again, like craniosynostosis surgery, has a very high rate of success. It depends on how you define it. So about 80 to 90% of patients will have improvement in their symptoms, particularly if those symptoms are headaches. If they have a syrinx and they have symptoms from their syrinx, trouble walking, gait instability, or pain, which is what you have when that syrinx is expanding and pushing on the spinal cord, then the rate goes down a lot. We're hoping to stabilize those symptoms, but the rate could go down to 50% or lower. So we try to treat syrinxes when we see them because those are less likely to revert. And so you try to be a little more aggressive at treating those and making them better. The complications most commonly are wound problems, especially if you have CSF there. You can have chronic or persistent pain from the surgery. That's less common, particularly in young kids, because they just don't complain ever. That's why everyone loves operating on kids. They're awesome. You can have drainage of spinal fluid. That rate is about 10% with the intradural surgery, and so that's why we try to avoid that unless kids really need it. You can get hydrocephalus, which is the buildup of spinal fluid, either from an infection or incomplete surgery, or from an underlying hydrocephalus or that was unmasked from doing the surgery. And then this chemical meningitis is something that we sort of fight all the time. So just in summary, kids with metabolic bone disease are at increased risk of developing those two conditions. You guys know this sort of more than I do. Undiagnosed or untreated craniosynostosis is a really big problem. Not all kids need surgery, but if they have those two disorders, they need to be followed so they can get their surgery sort of earlier and do better with that earlier surgery. Treatment for these two conditions, I think, are best, not that everyone's going to do a lot of metabolic bone disease, but if you do 3 to 4 surgeries a week with kids who without metabolic bone disease, it makes your center a little bit probably more facile at treating kids with an extra curveball in there for the surgery. And I think even more so today, maximizing the kid's metabolic bone disease before treatment is not just ideal, it's necessary. The kids need to have that bone as healthy as possible to get sort of the maximal treatment from the surgery. And so I don't mind people sort of contacting me for questions, and then I can sort of muscle your neurosurgeon into doing something for the surgery or other things. I'd just like to thank Deborah, actually, who's I've known for a while. I think she's a force of nature, sometimes good. Sometimes, you know, a nice misty rain like that ride at Disneyland, the Soarin' ride, and sometimes she's a hurricane, but she's still a force of nature in both ways. And so I want to make sure you guys realize, as from the other side of the curtain, as doctors, we also have kids and want kids to do the best. And so don't be embarrassed to advocate for your kids. If they can't handle it, then the doctor's a wimp. In some respects, though, he or she, they might be right too. So it's sort of a dialogue back and forth. And I think you guys advocating for your kids is going to improve the care for kids with less complicated Chiari's and craniosynostosis or other kind of metabolic bone disease. So I am really happy to be here.